Good morning, London. Great to be here. I've come from North Berwick, actually. So, anyone been to? No, that's okay. Not anyone been to North Berwick? I don't suppose a few hands yet. So, I know you've been to North Berwick. It's a wee coastal town, actually, just east of Edinburgh. And I've been a partner there 10 years now, and I have a long-standing interest in diabetes and medical education. And actually, believe it or not, this wasn't my first choice suit for today. It was actually this. But my wife wouldn't let me wear it this morning. This is I've got a proper little mini-me. These are my conflicts of interest. So I also speak for a number of different companies, but that gives me a well-balanced view of the evidence out there and puts me in a good position as well to make that judgment call about what therapy I should choose next for that person sat in front of me, okay? And happy for you to take pictures of my slides, happy to share my slide deck as well. So this is what we're going to talk about today. I'm going to put a lot about what we heard from Miles into practice. How is it going to change what we do in practice tomorrow? I'm going to talk about evolving guidelines for type 2 diabetes in primary care and when to consider these newer therapies like the GLP-1s and the SGLT2s. But equally importantly, I'm going to talk about the safety profile of these newer therapies. We must, of course, always ensure that risk-benefit remains favorable. And yes, while we have these compelling new cardiovascular and renal properties of these newer therapies, we have had a number of safety concerns highlighted. And I'm sure we all well remember the rosiglitazone debacle we've heard about already. And also, there was a coxib as well, and the more recent HRT scare in breast cancer as well. So it's these safety concerns that I do want to focus on. And then the final point I'll take you through is appropriate de-escalation of therapies. We're very good, aren't we, as GPs, as nurses, as pharmacists, at starting drugs. We're not so good at stopping drugs. So especially in the context of frailty, actively de-escalating diabetes therapies. Yes, we have these new compelling therapies, but we don't have to use them all the time. So let's start with a patient that we might all see in primary care. This is Gregor, one of my patients I saw not so long ago, 52 years old, recently actually suffered a non-ST elevation MI. He's had type 2 diabetes for relatively a few years, just a couple of years, and also a background of hypertension. Current BP, 126/74. HbA1c, 64 millimoles per mole, or 8% in all money. Total cholesterol, 3.9. LDL, 1.8. His BMI is 33. His renal function is okay, eGFR over 60. And unsurprisingly, he's on quite a number of medications because of his comorbidities. For his diabetes, he's on metformin, 1 gram twice a day, which he's tolerating okay. Lisinopril, 20. Atorvastatin, 80, that whopping great secondary prevention dose recommended by NICE that generally I find isn't tolerated so well in primary care. Bisoprolol, 10. And he's on dual antiplatelet therapy because he has a stent in situ. He works as an architect, and he's back to work already after his NSTEMI, and he's an ex-smoker. So first question, and only question in this presentation, ladies and gentlemen, what might you consider next, specifically with respect to his glucose-lowering therapies? Would you not make any changes to his current drug regimen and reinforce that all-important lifestyle advice? Lifestyle modification, as we've discussed this morning, is the cornerstone, isn't it, of all diabetes guidelines. We must educate before we medicate. The first step of healthcare is self-care. And Gregor's always telling me, Kevin, I just can't do it. Diabetes, blood pressure, obesity run in the family. And I'm always telling him, it's not the fact that diabetes, blood pressure, obesity run in the family. It's the fact that nobody runs in your family. Okay, so we have to hammer home that lifestyle advice. I'm with your colleague at the top left there, okay? Or would you add in a drug? Would you add in a sulfonylurea, pioglitazone, a gliptin? I know you won't, Miles. SGLT2 inhibitor, or an injectable, a GLP-1, basal insulin, or would you do something else altogether differently? Do you want to just shout out some answers? What do you reckon? Number 5, okay. 5, everyone's going for 5, right. So we are in a new and exciting and challenging time, aren't we, in primary and secondary care, because we have drugs now that not only just lower glucose, we also have drugs that improve cardiovascular outcomes. And as we heard from Professor A in that first session, despite all the good work we do in primary care, cardiovascular disease remains the leading cause of death in people living with type 2 diabetes. Someone like Gregor with type 2 diabetes is approximately twice as likely to suffer a fatal cardiovascular event compared to someone without type 2 diabetes. And look at this. Guidelines, diabetes guidelines across the world are changing to encompass this new and seminal cardioprotective data. And what's the odd one out on that slide, ladies and gentlemen? Nice. Yeah. And we all share a view on NICE here in the Scottish corner at the front here. In fact, in Scotland, we're always told that NICE stands for National Institute for the Curtailment of Expenditure. So I'm going to focus, though, here on some key take-home messages from the updated SIGN Diabetes Guideline that was published approximately 2 years ago. Very relevant to everyone else working outside Scotland, too, because I'm sure NICE will produce a robust guideline, but we're not due for an updated NICE guideline probably till early 2021. So that's why it's important we're all aware of this key new pivotal cardioprotective data, and we start implementing it now in day-to-day clinical practice. You know, it's estimated in primary care we get 250 guidelines and algorithms a year across all clinical specialties. That's 5 a week. And, you know, guidelines can be helpful, can't they, by promoting beneficial interventions, discouraging ineffective interventions, and at the same time, maintaining a consistency of care. But guidelines can also be harmful, can't they, when recommendations are based on subjective judgment, misinterpreted evidence, or most importantly, when they don't take into account a person's individual circumstances. And very much the theme of the SIGN guideline, and indeed a lot of these other diabetes guidelines, is the individualization of diabetes care. We need to look now not just at the glucose-lowering properties, not just the diabetes. We need to look at significant comorbidities, such as cardiovascular disease and renal disease. And that brings to mind one of my all-time favorite medical quotes, and very apt, isn't it, here in the college to be talking about Sir William Osler, the late, great Canadian physician. The good physician, or nurse, or pharmacist, treats the disease. The great physician treats the patient who has the disease. We tend to think of individualized care as a more recent development, but this quote was delivered over 100 years ago. So this is the new SIGN diabetes algorithm. So I'd very much encourage you to download this. You can get it as a PDF from the SIGN website. I think it's very user-friendly, very patient-centered, person-centered. And the key addition I've highlighted here, there's a row for cardiovascular benefit of drug classes. So that's the key change for us all to consider in primary care. When we're looking at people like Gregor, who, I don't need to tell you, is at high risk of a recurrent cardiovascular event, isn't it? We need to consider drugs with cardiovascular benefit. So I would thoroughly recommend you download that algorithm, and I'll show you another tool I've put together as well shortly. So here are the 2 key recommendations from the updated SIGN Diabetes Guideline. For people like Gregor with type 2 diabetes and coexisting cardiovascular disease, be it ischemic heart disease, peripheral vascular disease, be it a stroke disease, we should preferentially consider an SGLT2 with proven cardiovascular benefit. And at time of publication of SIGN, that was empagliflozin and canagliflozin, but that now also encompasses dapagliflozin. And similarly, for people like Gregor with type 2 diabetes and coexisting cardiovascular disease, if we're going to consider a GLP-1 drug or injectable drug, use a GLP-1 with proven cardiovascular benefit. And again, at time of publication, that was liraglutide, but now includes also dulaglutide and semaglutide as well. Okay, some practice-changing points for us there in primary care. So a great idea for a quality improvement activity in our relevant practices. Look at your registers of people with type 2 diabetes and coexisting cardiovascular disease and have a conversation about adding in or switching in a cardioprotective medication. And Europe have taken things one step further. So this is a joint consensus statement. So not a guideline, importantly. This is joint expert opinion from European diabetes associations and American. And what they're telling us is very similar. So in that person sat in front of you with type 2 diabetes, if atherosclerotic cardiovascular disease predominates, then use a GLP-1 with cardiovascular benefit or an SGLT2 with cardiovascular benefit, if eGFR is adequate. And I know that question popped up a few times. Don't worry, I will be covering that. However, if heart failure or CKD predominates, then we should preferentially use an SGLT2 with evidence of reducing heart failure or CKD progression. So real change in thinking for us, isn't it, in primary care? Not just looking at the diabetes, but looking at significant comorbidities as well. And just to touch on those renal benefits a bit, because I know that's caused a wee bit of confusion, hasn't it, in primary care? Currently, all available SGLT2 inhibitors in the UK can only be initiated if eGFR is above 60. But as Miles has already told us, we've had our first dedicated renal outcome SGLT2 study earlier this year, which has shown significant reduction in things such as end-stage renal disease, the requirement for dialysis, renal death, with the SGLT2 inhibitor, canagliflozin. And we've got other ongoing dedicated SGLT2 outcome studies in renal disease for the other SGLT2. So in my opinion, I think it is a class effect, and that was very much mirrored in this large systematic review and meta-analysis just published a couple of months ago in the Lancet Diabetes Endocrinology. Our findings provide the strongest evidence yet that SGLT2 inhibition should be routinely offered to individuals with type 2 diabetes at risk of progressive kidney disease. So our nephrology colleagues, our cardiology colleagues, our diabetes colleagues, and us in primary care, it's a real change in thinking for us required when looking and prescribing diabetes drugs. Of course, as Miles pointed out, the current challenge for us, this is at odds with our licensing indications of SGLT2s. But that will change, as Miles said. I fully expect it to change by the middle of next year. So I reckon within 6 months, we'll be prescribing SGLT2s down to an eGFR of 30. That was the sort of group of individuals recruited into many of these studies, okay? But we also have to be aware of when we perhaps need to step back from guidelines. We should always consider guidelines as handrails and not train tracks. And we should have the confidence to deviate from guidelines when we feel it benefits that patient sat in front of us. This was a very controversial European Society of Cardiology guidelines published in conjunction with the EASD, the European Association for the Study of Diabetes, just in September this year. And they somewhat controversially demoted metformin. And they suggested we use SGLT2s first line for people with cardiovascular disease and type 2. But that doesn't follow the evidence. All those studies Miles took you through, it was add-on therapy to metformin. So ultimately, it's our signature on that prescription, isn't it? We need to make that evidence-informed yet person-centered decision to prescribe an SGLT2 or, say, a GLP-1. So have the confidence to deviate from guidance where it doesn't seem to benefit that patient in front of you. So very much, as I've summarized in this first section, the direction of travel are these newer therapies. And this was the front cover of the Lancet at the beginning of the year. Another big meta-analysis suggesting that SGLT2 inhibitors should now be considered first-line therapy after metformin in most people with type 2 diabetes. A big, bold statement there. But in the second section, I'm going to very quickly take you through some of the key safety concerns. Because, of course, no drug is without harm. This is another one of my favorite quotes by Paracelsus. He was a Swiss-German Renaissance physician and the founder of the discipline of toxicology. Poison is in everything, and no thing is without poison. The dosage makes it either a poison or a remedy. So when I prescribe any new drug, diabetes drug, I ask myself a simple question. Is this a drug I'd give to my own mother? Or is this a drug I'd prefer to give to my mother-in-law? And ladies and gentlemen, SGLT2s are fine for my mother, you'll be glad to know. But just very quickly, a couple of quick safety updates here. So the first, as you've heard about briefly already, is this issue of DKA, diabetic ketoacidosis. We had an MHRA alert about this during 2016. And the first thing we should be aware of, it's a rare adverse event, 1 in 1,000 to 1 in 10,000. And the MHRA do reassure us the benefits outweigh the risk for the majority of people with type 2 diabetes. The challenge, though, it's a euglycemic DKA. So glucose levels are normal or near normal because that individual is peeing out that extra glucose. So what should we do in primary care? Well, when starting an SGLT2 inhibitor, we need to counsel patients about the signs and symptoms of DKA, which is a challenge in itself, isn't it? It's very non-specific: abdominal pain, nausea, vomiting, malaise. And if we do suspect it in clinic due to surgery, we need to check for ketones, even if glucose levels are normal or near normal, because of the euglycemic nature. So check, ideally for blood ketones. If not, urinary ketones is fine. But importantly, we don't need to issue ketone testing strips to those on SGLT2 inhibitors. That had caused a wee bit of confusion for us in primary care as well. So there are some groups of individuals who are more likely to develop DKA. Those with a longer-standing type 2 diabetes, Miles mentioned this group, they may have less beta cell function, more likely to get DKA. Those who are malnourished or dehydrated. Sudden reduction in insulin as well, Miles mentioned, that can precipitate DKA. So we need to be very cautious, 10 to 15% as was mentioned. Acute illness, post-surgery, and alcohol abuse. It's not contraindicated to use SGLT2s in these scenarios, but we should maybe just reassess that risk-benefit ratio. So very much, we in primary care need to discuss sick day guidance to anyone on an SGLT2 inhibitor. We need to temporarily stop that SGLT2 inhibitor during any acute dehydrating illness. So a really useful mnemonic here is SADMAN. Temporarily stop the SADMAN drugs during any acute dehydrating illness, such as diarrhea and vomiting. Stop the S for SGLT2 inhibitors, A for ACE inhibitors, D for diuretics, M for metformin, A for ARBs, and N for NSAIDs. But importantly, restart them once patients are eating and drinking normally, usually 24 to 48 hours. Because if my patients are anything like yours, they see that as carte blanche, never to take their drugs ever again. So stop the SADMAN drugs, but restart them once they're eating and drinking normally. And in Scotland, every GP, nurse, and pharmacist have given these sick day rule cards with those SADMAN drugs and some space to write other drugs. And so these have already, we've had observational data, these have already reduced admissions with acute kidney injury. So these are part of the NHS polypharmacy guidance. So you can Google these and just use those for your own purposes. And DKA has also been highlighted as an issue with GLP-1s. This was an MHRA alert just from June. Rapid discontinuation of insulin alongside a GLP-1 can also sometimes precipitate DKA. So really the key take-home message for us, ladies and gentlemen, we need to be cautious when adding these newer therapies alongside insulin in terms of reducing insulin to prevent precipitation of DKA. Second safety alert, very quickly, this issue of amputations that was asked about earlier on. So the CANVAS trial program looked at canagliflozin and showed these compelling cardiovascular properties, but showed a small but significant increase in lower limb amputations, particularly toe amputations. So how can we make sense of this in primary care? Well, subsequent to that study, the EMA called a review of all SGLT2 inhibitors, and the MHRA also published alert, importantly suggesting this may be a class effect rather than just an effect of canagliflozin itself. Now, this is a very contentious issue. This is debated a lot by my colleagues. I personally think it may be a class effect because we've had some recent unblinded data from the ertugliflozin trial, which has actually shown also a small increased risk in lower limb amputation, toe amputation. Small numbers, we need to wait for the full trial data. So what my advice here is reinforce preventative foot care in anyone on an SGLT2 inhibitor, which we should be doing anyway for anyone with diabetes, and alert them to the signs and symptoms of PVD. But I suggest in primary care we avoid all SGLT2 inhibitors in those with symptomatic PVD or a history of active or past diabetic foot disease. Of course, by definition, that person with PVD would benefit from a cardioprotective drug, so I would give them a GLP-1 with cardioprotective effect instead, okay? And then the third safety alert, you probably saw, we all got a mail shot about this, the risk of Fournier's gangrene or necrotizing fasciitis of the genitals. So not good news for Gregor. I can stop him having another heart attack, but his willy's going to fall off. You know? So it's all about perspective here, isn't it? The MHRA published a report in February 2019, and actually they tell us there were only 6 yellow card reports in nearly 550,000 patient years of treatment. And also the DECLARE-TIMI trial, the dapagliflozin trial, a large trial, 18,000 patients. They looked specifically for Fournier's gangrene, no imbalance between the placebo arm and the dapagliflozin arm. So I'm personally not worried about it, and if I told my patients about this, no one would take this drug, would they? So I do reinforce, though, the importance of good personal hygiene, and of course, to report any concerns about erythema, swelling, inflammation in the genital or perineal area. Okay? So I've put these, with my GP notebook cap on, I've put these 2 tools together for primary care. What next after metformin? I'm happy to share that with you all. And also prescribing in diabetes and coexisting CKD. Just some clinical aid memoirs to make life a wee bit easier. So happy to share that after today as well. And in the last minute, I'll quickly tell you about escalation of therapies. Yes, we have these new therapies, but we don't need to use them all the time, do we? Especially in the context of frailty. What is our goal of treatment? Why are we treating diabetes? Is it to improve quality of life, treat the symptoms of diabetes, or is it to improve quantity of life and reduce cardiovascular complications, or indeed both? And this is a lovely quote. What do we want? Do we want to add years to life or life to years? Very much the theme of Atul Gawande's book, which I'm sure many of you read, Being Mortal. We tend to over-medicalize old age, don't we? We all are going to die of something at some point, aren't we? So very delighted to see this produced by David Strain, one of our diabetes colleagues, that very much tells us the importance of treatment targets in the older person. But age is irrelevant, isn't it? What's more relevant is functional status. So, of course, in that fit older adult, aim for that slightly tighter HbA1c. But very importantly, this table gives us de-escalation targets, targets that we need to actively stop diabetes drugs. So in the moderate or severely frail drug, even if that HbA1c hits 64, actively stop diabetes drugs. Again, what's our goal of treatment? To add years to life or life to years. We want to avoid harms such as hypoglycemia. And weight loss with SGLT2s and a GLP-1 can be harmful in a more frail person as well. So very much encourage you to have a look at that. So to conclude then, returning to these newer therapies, have we found the holy grail of type 2 diabetes management? That intervention that improves quality and quantity of life? Perhaps. But we must never forget about glucose and never forget about lifestyle, because one of my other favorite quotes, who I couldn't quite pin down who could say this, there's no such thing as a sudden heart attack. It takes years of preparation. So my 3 key home messages for you, ladies and gentlemen. Individualized diabetes care. Consider cardiovascular and renal benefits of diabetes therapies and not just their glucose-lowering properties. But don't ever forget about glucose. Glucose hyperglycemia is the leading cause of blindness in diabetes in the UK. No drug is without harm. Our first principle of medicine, primum non nocere. We must always ensure benefits of treatment outweigh any harms. Discuss sick aid guidance. Temporarily stop the sad man drugs. And finally, what is our goal of care? Quality of life or quantity of life? Do we want to add years to life or life to years? De-escalate diabetes therapies in frailty. Thanks very much for listening.